This is part 2 of the lecture Fluid and Electrolyte Imbalances and Surgical Nutrition by Dr. Hesham Akkad, Professor of General Surgery, Ain Shams Medical School. In part 1, we have discussed pure volume abnormalities. We start now with concentration abnormalities. In this entity, the net volume of fluid loss or gain contains water and sodium, but in proportions different from their proportions in the extracellular fluid. That is to say, there is no volume abnormality, but the extracellular fluid becomes either hypotonic or hypertonic regarding its normal concentration. If a certain volume of extracellular fluid is lost and was compensated for with equal volume, but this compensation was with hypotonic solutions which contain much less salt than that present normally in the extracellular fluid, then the volume will be restored to normal, but the extracellular fluid will contain less sodium than normal. This is hyponatremia with normovolemia. It is a pure concentration abnormality. Actually, the amount of water in the body is not in excess, but there is relative water excess in respect to the osmolality of the extracellular fluid and its sodium concentration. This occurs clinically if GIT losses are fully compensated for with hypotonic or salt-free solutions. Hyponatremia develops, meaning decreased plasma sodium concentration. Clinical signs of hyponatremia are mainly central nervous system irritation, and the nausea and vomiting are not of gastric causes. In mild to moderate hyponatremia, the kidneys will excrete more water than sodium, and the homeostasis is restored. In severe cases, the hyponatremia-induced convulsions will need rapid correction of the hyponatremia by small volume of hypertonic saline. This small volume will not cause appreciable hypervolemia, but adds enough salt to correct the hyponatremia. If some of the fluids lost from the body are hypotonic or almost pure water without any salt, if these losses are compensated for by isotonic salt solutions, hypernatremia occurs despite the restoration of volume. Substantial amounts of water vapor is lost through a tracheostomy. Polyuria due to diuretics contains low salt content. Sweat contains only half the concentration of sodium in the extracellular fluid. If such losses are replaced with isotonic or hypertonic solution, hypernatremia occurs. The clinical signs of hypernatremia are shown in the slide. In order to correct the hypernatremia, we need to add pure water to the extracellular fluid till the sodium concentration drops to normal values. The amount of pure water needed for correction can be estimated from the plasma sodium concentration as shown. For treatment, pure water without salt is given as IV dextrose 5% solution or as drinking water in mild to moderate cases. We have discussed now pure volume abnormalities and pure concentration abnormalities. But often the abnormality is a mixed volume and concentration types. The signs and symptoms tend to be an algebraic composite of each state. An example is partial compensation for isotonic losses, hypovolemia, by hypotonic solutions. Hyponatremia develops while the patient is still hypovolemic. I think you can pause and read yourselves the rest of the slides about mixed volume and concentration abnormalities. I shall resume the explanation from composition abnormalities. Composition abnormalities include other extracellular fluid ions like potassium, magnesium, and others. This presentation shall explain potassium abnormalities as the most common. Please read the magnesium yourselves. Although the body stores of potassium are about 3,500 milliequivalent, yet the amount in the extracellular fluid is small and its concentration in plasma is only 3.5 to 5 milliequivalent per liter. However, the effect of this small concentration on the myocardium, nerve conduction, and muscle contractions is profound. The very narrow range of normal concentration, which is already small, makes any minor fluctuations in the plasma concentration of hazardous consequences. The condition is more complicated by the fact that plasma potassium levels are affected by acidosis and alkalosis. Unlike sodium, potassium plasma reflects total body potassium. You can estimate total body potassium excess or deficit from its plasma concentration as shown in the slide. But in case of acid-base imbalances, the estimated potassium excess or deficit must be corrected. Hydrogen ions can move in between fluid compartments. With acidosis, hydrogen ions inside the cells increase, so potassium ions move out of the cells to maintain electric neutrality inside the cell. There is special hydrogen-potassium pump in the cell membrane or that. When the acidosis is corrected, the potassium which moved out shall move in again. So during acidosis, plasma potassium shall reflect false higher levels of body potassium, and the opposite with alkalosis. Note that the clinical effects of potassium are dependent on its plasma concentration and not on the body stores. It is true that plasma potassium reflects body stores, but we have seen that plasma potassium levels are affected by factors like acidosis or alkalosis. Whatever the cause, the physician should struggle to maintain plasma concentration level between 3.5 and 5 milliequivalent per liter at any moment. This slide demonstrates some clinical conditions leading to hypokalemia. Hypokalemia should be expected if clinical conditions leading to it are present. Plasma levels should be closely monitored through frequent estimations. If clinical signs of hypokalemia develop or if plasma concentration drops, ECG monitoring is mandatory. The amount of parenteral potassium therapy per day to correct hypokalemia is limited by the maximum concentration of potassium allowed in the perfusion fluid and by the maximum rate of perfusion allowed. Higher rates and concentrations can be given under continuous ECG monitoring in the ICU rather than in the ward. So extensive potassium therapy should not be conducted in the ward. Rapid infusions can lead to cardiac arrest. Potassium replacement therapy includes administration over the following 24 hours of half the calculated deficit, plus the expected excessive losses over the following 24 hours like from a high output intestinal fistula, for example, plus the normal daily need. Calculations must be repeated daily, and the treatment is prescribed on daily basis for only the following 24 hours, and so on. Except from iatrogenic causes, in surgical patients, hazardous hyperkalemia is most commonly due to crush injuries, intravascular hemolysis, and ischemic reperfusion injuries that might themselves lead to acute renal injury that further aggravate the hyperkalemia. With hyperkalemia, plasma potassium must be promptly measured and ECG monitored for characteristic changes described in this slide. Respiratory paralysis must be managed by intubation and mechanical ventilation. As stated before, the target is to restore normal potassium level in plasma and extracellular fluid. Intracellular potassium is never the issue in hyper or hypokalemia. In hyperkalemia, lowering plasma potassium is achieved through pushing the extracellular potassium into the cells by the effect of insulin glucose solution. If there is associated acidosis, the treatment of acidosis per se shall cause the potassium that moved out of the cells to move back into the cells. The effect of potassium on cell membranes like the myocardium and nerve and muscle cells is antagonized by calcium. The route of getting rid of excess potassium in the body is the kidney. If there is oliguria, for example, secondary to associated hypovolemia, correction of volume deficit and establishment of good urine output is crucial. If re-establishment of urine output is not possible, dialysis will be needed. Now we are going to discuss the acid-base balance. You will have to memorize these normal values. Bicarbonate level is concerned with metabolic acid-base imbalances. Its elevation leads to metabolic alkalosis, and its decrease leads to metabolic acidosis. PCO2, on the other hand, is concerned with respiratory acid-base imbalances. PCO2 increase leads to respiratory acidosis, and its decrease leads to respiratory alkalosis. Metabolic acidosis occurs with shock and sepsis and is the leading cause of metabolic acidosis in surgical patients. Except for pyloric obstruction, all other GIT losses will cause metabolic acidosis due to bicarbonate losses in the intestinal and pancreatic juices. Renal failure is the third common cause of metabolic acidosis in surgery. In the surgical patient, the most common cause of metabolic alkalosis is pyloric outlet obstruction on view of the loss of acidic gastric juice. Other causes of metabolic alkalosis are rare in the surgical patient. Respiratory acidosis is due to carbon dioxide retention and is associated with any cause of airway obstruction or decreased pulmonary ventilation. In the surgical patient, respiratory alkalosis is usually compensatory to metabolic acidosis. Patients who have metabolic acidosis due to shock or sepsis, for example, will hyperventilate and wash away carbon dioxide in trial to elevate the pH of arterial blood and counteract the metabolic acidosis. In this table, first look at the pH figure and see if there is acidosis or alkalosis. Then look at the bicarbonate and the PCO2 levels. The level of either or both, which is in accordance with the pH status, is the cause of the acid-base imbalance. The level which is opposite to the pH status is compensatory. Pause the video and try to figure it out. We are going to discuss it in the face-to-face session. The following slides will be isolated clinical entities. Study each. You shall be asked to explain them in the face-to-face session. Thank you. We are going to continue this topic in part 3.